Good morning, everybody. Good afternoon. Good evening. Today we're going to talk about the wrist. So I strongly encourage you to open your PowerPoint on or title to wrist, and there is some couple maybe slides which need explanations to a certain extent, and the rest is pretty straightforward anatomical features. So let's just start. So the very first slide which simply just says wrist. So wrist contains of 8 small bones which we are going to call carpal bones. And again, my eyes sometimes will drift to the side. I'm not gonna look straight at you because I am following directly the PowerPoint, so I know exactly where I am, where you are, so we are exactly on the same page. Okay, I hope you don't mind me not looking directly at you. Okay, so the wrist works as one unit. So all of those 8 bones are really tied together by very strong ligaments. They could be their external or internal ligaments. We're going to talk about them in more details very shortly. So what the wrist can do? So wrist has 2 major articulations. The first one, very important, is called radiocarpal joint. Radiocarpal joint. It is located between the distal end of the radius and the proximal row of the carpal bones. So as you well know, the wrist has 2 rows of carpal bones. This one is distal and this one is proximal. So the proximal, of course, connects with the radius and ulna. So the radiocarpal joint. The second important one is midcarpal joint. It is located between the proximal and distal row of the carpal bones. So again, if this is my wrist right here, this is proximal row, this is distal row, so the connection between those 2 rows. Okay, it's a midcarpal joint. Okay, so what can we do with those joints? Well, as you know from previous lectures and from your anatomy classes, the wrist can do 2 things, or it can move in 2 degrees of freedom. It's flexion, neutral, extension, neutral, radial deviation, neutral, ulnar deviation, neutral. That's it. This movement, it's called again circumduction, and of course you know that circumduction is not a rotation, it's just a combination of flexion, extension, radial and ulnar deviation. So therefore we will not count this as a 3rd degree of freedom. So the position of the wrist is described either as palmar or volar or dorsal. This is volar or palmar, and this is of course dorsal. And this comes true to hand, wrist and forearm as well. We will use the same terminology. I apologize, my throat is already acting up. So let's go now to the next slide, which simply says bones of the wrist. So this is anatomy. Please take a look at that. Again, I will not give you picture and ask to name bones. This is for your own mental picture. As we talking about wrist, I would like you just to have that in mind, kind of picture where we are at the point of discussion. Okay. So let's just simply go to the next slide. And this slide, which says palmar and ulnar tilts, is very important. Okay. So those are anatomical features, and you can clearly see that when you look at the wrist, more precisely the radiocarpal articulation, right, or the place where the radius and ulna meets the proximal row of the carpal bones, you have an inclination of the radius. The radius is slanted up and goes towards the ulna. It's called ulnar tilt, and on average it's approximately 25 degrees. Of course, degree this way or that way wouldn't make any difference, but this is our anatomy, and on average is 25 degrees. So the importance of that feature, we will talk about that, and I will demonstrate to you in just a few minutes, but please keep that in mind because it will come important as come to our physiology and what we can actually do with our hands, and this ulnar tilt will influence that. Same thing when you look at the same part of your body from the medial view. You can clearly see that again radius is slanted, is inclined, and this time to the back. Okay, so this is again approximately 10 degrees into the palmar direction. To be more precise, it's a palmar direction. So what is the significance of those features, this ulnar tilt and palmar tilt? Well, the palmar tilt will give us more wrist flexion as opposed to wrist extension. And if you quote unquote normal or stereotypical, let's say, you will have more flexion than extension, and you will feel different when your hand goes down or up. This requires much more energy, not only because you're fighting against gravity, but because of this palmar tilt. Similarly to the ulnar tilt, it's easier to go towards the ulna and you can have more range of motion rather than radius. And again, going towards the radial deviation is not as comfortable, doesn't feel right, so to speak. And you have more ulnar deviation than radial deviation because of the ulnar tilt. So those are very, very important features, especially for us as therapists, because we have to understand this anatomy. If we are performing passive range of motion, for example, with our patients, or we're measuring range of motion, we have to be aware of the natural limitations. Okay, let's go to the next slide. I think I explained everything on this slide. So joints of the wrist, the primary joints are radiocarpal and midcarpal. We just talked about them. So those are two joints which are going to give you that gross or large range of motion of the wrist. However, there are more joints, articulations within the wrist itself. Remember, we have 8 bones, and each of these bones articulate with each other. Now, they can only slide, so all of them have really like 1 degree of freedom. They can only slide this way or this way, right? By themselves, hopefully, they won't move, right? Because they are really tightly packed together and held by ligaments. We don't want them really to move, otherwise the wrist would be weak and would not be stable. So really we talk about the wrist as a one unit, okay? But just so you know, there is a lot of actual joints because of the carpal bones themselves. Okay, let's go to the next slide, which is called bones of the wrist and is simple anatomy. So I'm not going to go through that because you can see it by yourself, of course. But you can find those bones and articulations and appreciate how an articulation is, for example, within the carpal bones. So let's go to the next slide. This one, it shows you carpal tunnel. Okay, so what are we looking at? I'm going to use my wrist. Here we are. So here are going to be your bones, and here it's going to be transverse carpal ligament. Transverse carpal ligament is made of the tough connective tissue and creates kind of like a dome roof right here. Okay, so carpal tunnel is very important, and from the therapy point of view, of course, is very important because, as you know, a lot of people in the United States, but also around the world, are suffering for disease or condition known as a carpal tunnel syndrome, which is inflammation of overused muscles, which then can cause, of course, compression on the medial nerve. So as you can see on this particular drawing, you can clearly see the transverse carpal ligament. You can see a tendon of certain muscles. Here presented are flexor digitorum superficialis, flexor digitorum profundus, flexor pollicus longus, flexor carpal radialis. But you also can see that very large, thick cable-like structure which we call median nerve. And you can clearly see that the median nerve is placed in between those wrist features. So if you overuse those muscles, or you use your hand in awkward positions, which eventually will cause internal inflammation, internal swelling, then you can clearly see this, that the median nerve could be compromised, being compressed, and of course then we have a problem. Does therapy work? Well, yes, it does. In most cases, in fact, people go for therapy before they choose or elect to go for surgeries. And that's a good thing. Surgery is really the last thing on your mind, and your patients as well. But sometimes it's too late for therapy, and no therapy in the world can help those patients. So they elect to go for surgery, and then you will see them post-surgically. But nevertheless, they will come for therapy. Okay, so let's go to the next slide. Right here. Okay, so we talk about those ligaments which are holding those 8 carpal bones very tightly, allowing the bones or the carpal bones to work only as a one unit rather than 8 separate bones, which would not be comfortable for anybody. So we have those extrinsic ligaments and intrinsic ligaments. So what are the differences? What are the similarities? The similarities, we already talked about it. They are provided stability to the wrist. But what are the differences? Well, differences are clear, and as suggested by the name themselves, extrinsic ligaments are going to originate outside the wrist and insert within the wrist. So to the contrary, intrinsic ligaments are going to originate and insert within the wrist itself. Okay, so let's talk about them in a little bit more details. Okay, so let's go to the next slide. And here we go. We have 4 different types of extrinsic ligaments. We got dorsal radiocarpal ligament, radial collateral ligament, palmar radiocarpal ligament, and ulnocarpal complex. The only one which we are familiar by now is ulnocarpal complex, which we already mentioned before. But nevertheless, let's talk a little bit, just a basic information about all of them. Okay, so the dorsal radiocarpal ligament are thin, and it's kind of difficult to differentiate them from the capsule of the wrist joint itself. When they become taut in full wrist flexion. Okay, and that makes sense when you think about it. Look at my wrist, and this is the dorsal side of the wrist. So by name, dorsal radiocarpal ligament, they're gonna be on the dorsal side closer to the radius rather than ulna. So they're gonna be somewhere right here. So when they become taut, of course, during the wrist flexion, you can see that they become very tight over here. When they become lax, when you are extending, there is no compression, no pressure exerted on those, and they're gonna become lax. Okay, so in other words, just by location of those ligaments in your body, you can already know what they are going to do and how they're going to be responsible for the stability of your wrist. Let's talk about a radial collateral ligament. This ligament is located at the lateral part of the wrist capsule, and its function is to strengthen, of course, the radial part of the wrist itself. This ligament becomes taut or tight when ulnar deviation is combined with wrist extension. Okay, so again, it makes perfect sense. Since this ligament is on the radial side, when you're going into ulnar deviation, like that, combine with wrist extension, just like that, this on the radial side, of course, this ligament becomes the most taut or tight. Okay, the third one is palmar radiocarpal ligaments. And I say ligaments because it's more than one. It's actually 3 separate bundles of those ligaments with 3 different names, but we're not gonna go there. You don't have to remember all 3 of them separately or where they are or what they do. Rather, that umbrella palmar radiocarpal ligament. So they are deep. They are completely separated from the capsule of the wrist itself, and they become taut at full wrist extension. Okay? The fourth one is ulnocarpal complex, consists of the articular disc, which again, remember from the previous videos, the articular disc is a fibrocartilaginous disc which improves congruity between the bones. Okay? So when the bones clearly wouldn't fit as well, nature is smart, provide us with this fibrocartilage disc to make it fit a little bit better. Okay. What else is there besides that articular disc? Ulnocarpolateral ligament and palmar collateral ligament. So this complex fills most of the ulnocarpal space between the distal ulna and carpal bones, and the ulnocarpal space allows carpal bones to pronate and supinate. So if you wouldn't have this particular ulnocarpal complex intact, supination and pronation would be very tricky because your wrist would really be not stable enough to sustain that movement, or even in a worst case scenario if you're holding something in your hand. Okay, so having said that, I think this is enough for the extrinsic ligaments. Let's go to the intrinsic ligaments, and again you have a lot of them, and they differentiate themselves or among themselves you can differentiate them by their size. So you got short, intermediate, and long. Okay, there is plenty of information in your book. I'm not going to ask you in such a specific details everything the book has to offer. All you need to remember that all 3 categories or sizes of those intrinsic ligaments have one task and one task only, which is to bind tightly those carpal bones and not allowing the wrist to go, the wrist bones or the carpal bones to go in the very separate way. Wrist should work as one unit. Okay, so that's all you need to know about the intrinsic ligaments. Let's go to the next slide. And here we are. This slide is titled Ligaments of the Wrist, and you have 2 pictures, drawings, really. So on one side you got dorsal view, and on the other side you got palmar view, and you can find those ligaments clearly on those drawings. So I suggest that you do that just for your own sake, just to have the visual map in your brain where is what. So when we are discussing features of the wrist, you have the understanding where is what. Okay, so let's go to the next slide. And this is motions of the wrist. What can you do with the wrist? We already know that. We already covered that. Flexion and extension and radial and ulnar deviation. And of course, each one comes with its own plane and axis of rotation. The next slide is just a graphical representation of those axis of rotations we talk about. So not much to discuss over here. Let's go to the functional wrist motion. Slide is titled Functional Wrist Motion. So we know already that what's normal, what's functional, it's not necessarily normal. Of course, every normal should be functional, but not every functional reaches the limits of normal. But if you don't know what is normal, then how would you know what's abnormal or functional? right? So we have to be aware what's normal. So before I said that we have more flexion than extension, and indeed that's true. Flexion we have from 0 to 80 degrees, or we should have, stereotypically speaking, or normal, and then extension is from 0 to 70 degrees, 10 degrees less. Remember those features of the radius, those tilts, yes, palmar and ulnar tilt. So normal flexion 0 to 80, extension 0 to 70, but what's functional? Well, you can see it on the screen. 5 to 10 degrees of flexion and 30 to 35 degrees extension is enough for most people to perform most daily tasks. And similarly with ulnar and radial deviation, what's normal? Radial deviation is 0 to 20, when ulnar deviation is 0 to 30. Again, like I mentioned before, the ulnar deviation is 10 degrees more. Why? Because of the ulnar tilt of the bones. So it's a normal anatomical feature of our body rather than some abnormality. But what's functional? What functional is only 10 degrees of radial deviation, as you can see on your PowerPoint, and only 15 degrees of ulnar deviation. So it is less, like I mentioned before. Normal numbers are always higher than functional. Okay, and again, if you have specific certain occupations or you are a professional athlete, you probably want to be normal or sometimes even hyper, right? Whatever the number is as normal. But for regular people performing regular daily tasks, functional is more important than normal. Okay, let's go to the next slide. And here we are. You have bones and muscles. Muscles responsible for particular movement, and on the next few slides you can appreciate the complexity of human body and how the muscles actually where they are in our body and what do they do. Now for our purposes on the test, I will not ask you to I'm not gonna give you any pictures and ask you to name them, but for your own sake, please again have this visual map, so when we are performing manual muscle testing and range of motion, the goniometry, you will have a clear understanding where is what. So the next slide, origins of the wrist flexors, wrist extensors, origins of the wrist extensors, ulnar deviators of the wrists, radial deviators of the wrist. Not every slide has pictures, but they could be fairly easily found in the anatomy book. Okay, so let's go to the next slide, which we will discuss briefly. It's called, the title of this particular slide is Arthrokinematics, Wrist Flexion and Extension. So again, you can see over here the middle picture. That's going to be our starting point. So this is neutral. Okay, so where is the middle of the wrist? Of course, the middle of the wrist would be the third digit. Oh, I'm losing here the line right here, right? So we ended up right here, which is the capitate bone. So we got third metacarpal and capitate bone. Okay, so what else can we see? Right below the capitate, approximately, it's a lunate, and of course, then above that would be a radius. Okay, so what can we see? We see that the wrist clearly is in neutral position. All the bones are nicely aligned. So what's going to happen during the extension? After all, we're going to discuss here extension and flexion of the wrist. On the left hand side, you have extension. So remember when we discuss how the bones are behaving, they can spin, then they can slide, they can roll. So all of that discussion was actually very important, because when we're talking about the interaction of the bones within the joint, then you will clearly see that those concepts actually come to play. So let's talk about the lunate. lunate, it's on the left hand side is the reddish bone, and the capitate is the gray one. So what's happening arthrokinematically speaking when you are extending your wrist, when you're going this direction, just like that? Well, lunate slides and rolls in opposite direction. And why do I say opposite direction? Look at the title, the name on the bone itself. It says slide, and the arrow is from right hand side to the left hand side. Above that you have a sign which is roll, right, written on the another red arrow which goes from the left to right. So clearly they are going in the opposite direction. But let's pay attention to capitate, which represents the lunate represents the proximal row of carpal bones, when the capitate represents the distal row of carpal bones. Capitate follows the suit. It rolls and slides exactly the same way lunate does, because we said they are so tightly so tightly connected by the ligaments that there is no way they can behave any differently. Without those ligaments, of course, who knows what would happen. And the entire wrist goes into extension. So let's go to the far right side when you have flexion. Everything what I just said about extension, just reverse it, and you have flexion. Now, what else is interesting over here? That you can see the palmar and dorsal ligaments. And remember what I said before: if you have a fairly straight arrow, not straight in this way, but drawn the way that you don't have those kind of spiral looking arrows, means that the ligament becomes taut or tight. But when you can see this kind of spirals, that means that the ligament are lax. So clearly you can see that when you are doing extension, of course the volar ligaments become taut and the dorsal become lax, and the opposite when you are going into flexion. Okay, let's go to the next slide. And I will try to do that. Okay, arthrokinematics now of radial and ulnar deviation. So again, we are in the middle of the wrist, right here. We're gonna take the third digit into consideration, going this way, going down. Okay, so of course we see the third metacarpal, and again we see the capitate, and as the representative of the distal row of the carpal bones, and lunate as a representative of the, actually in this case we have three bones, but lunate is still there as a representative of the proximal row of the carpal bones. In this case, authors decided to include all the bones of the proximal row of the carpal bones, but we can still keep in mind the lunate, because again, because of the strength of the ligaments, if one bone moves one way, other bones must follow. If they don't, that means the patient is in big trouble, and the wrist is pretty much useless at that point. So let's look at the middle picture again, and you can clearly see that all the bones are nicely aligned and the wrist is in neutral. But what's going to happen during ulnar deviation? Again, the capitate rolls and slides in opposite direction, but it's clearly and tightly followed by the proximal row of the carpal bones, in this case represented by the lunate, and everything goes towards ulnar deviation as one unit. What can we see on the far right side, radial deviation? Well, everything what I just said about ulnar deviation, just reverse it, right? So capitate rolls and slide in also in opposite direction to itself. but also in opposite direction, what you saw during the ulnar deviation. Similarly, the lunate and the entire proximal row of the carpal bones follow suit, and the entire wrist goes to radial deviation. So this is arthrokinematics of the radial and ulnar deviation. Okay, let's go to the next slide. Okay, the motion of the wrist. Now let's talk about the motion of the wrist, right? Is caused by muscles, of course, but the stability of the movement is controlled by the passive tension of the ligaments. Remember, ligaments, they don't have the ability to move by themselves. They are really passive structures. Okay, a double V system, that's what you can see on this particular screen. A slide is called double V system ligaments. That's where I am. So a double V system of ligaments illustrates how ligaments help to control ulnar and radial deviation. So if the wrist in neutral position, all 4 ligaments are equally taut. They become tight, but not too tight, right? They evenly, nicely taut. And you can see those V's actually are inverted. They look like this, right? And you got one on your screen would be above and below. Of course, the one below, it's called proximal because it's closer to your head, and the one above on the screen would be really the one below in your body, right? So just to orient ourselves. Okay, so the distal V, it's composed of medial and lateral legs of the palmar intercarpal ligament. Now, the proximal inverted V represents palmar ulnocarpal and palmar radiocarpal ligaments. So in neutral position, all of the wrist 4 ligaments are slightly tense, as I mentioned. We're going to call it slightly taut, right? But during ulnar and radial deviation, the tensions are actually changing on the diagonal pattern, okay, diagonal pattern. Okay, and you can clearly see that tension rises diagonally in the lateral leg of the palmar intercarpal ligament and palmar ulnocarpal ligament during ulnar deviation. So during radial deviation, tension rises in the medial leg of the palmar intercarpal ligament and palmar radiocarpal ligament. So again, look at the picture. You got one V and the other V, and when you're doing ulnar or radial deviation, those ligaments are going to either become taut or relax in diagonal pattern. Okay, and as you can clearly see, are those intrinsic or extrinsic ligaments? The answer is, of course, all of them are intrinsic. Actually, I take that back, because the proximal V is extrinsic. We can see it because when you pay attention, they are going from, or at least that the arrows representing them are going from the proximal row of carpal bones, and they are attached to ulna and the radius. So those are going to be your external ligament. The internal ligament, of course, are going to be the ones on the above V on your picture or below in your real body, which are, of course, originating and they insert within the wrist. So this is an example. That WV system is an example of 2 internal and 2 external ligaments. Okay, let's go to the next slide. Try to find it over here. Okay, so let's talk about the role of the wrist flexors in finger extension. counteract force of finger extensor, which would extend wrist with finger extension. Okay, we're gonna talk about that in a second, but let's go to the next slide, because I think if I show you, I can show you both at the same time. Here we are, role of the wrist extensor in your grasp. Well, counteract force of long finger flexors, which contribute to wrist flexion, otherwise grip would be weaker. Harder the grip, greater contraction of the wrist extensors. Okay, let's talk about both of those slides at once. Okay, so I'm going to demonstrate to you just to so clarify this semi-unclear text over here. And again, those pictures are taken from the book. So what I would like you to do, you can do it with me, would be fantastic, when you close your fist just like I did right here in most natural position. Of course you can do it like this, or you can do it like that, but you have to put some conscious to it. If you just nicely close your wrist without thinking about it, it is slight, it should be in slight extension. Some of you might have this a little bit here, but it really, the most comfortable position, it's just like that. Okay, so it's slight wrist extension. Now what's gonna happen when I'm extending my digits? There we go. I'm gonna extend my digits and look at my wrist. Clearly my wrist is going into extension as I am flexing my digits, or my wrist goes into slight flexion to neutral position as my digits extend. Why does this happen, and what is this all about? Where extensors and flexors, the digital flexor and extensors are strong. In fact, even the wrist flexors and extensor would automatically kick in if left to themselves. So again, my wrist is in the slight extension. I'm just holding my wrist not too tight, just made the fist. So now if I would go to digital extension, but my wrist flexors would be very weak, then extensors are very strong. So what would happen, that every time I open my hand would go automatically to this position. Okay, why? Because there is no muscles to contradict those strong extensors. Similarly, if I'm closing my digits, I'm making the fist. Without strong wrist extensors, the digital flexor, like flexor digitorum profundus and flexor digitorum superficialis and other wrist flexors, are very strong. Every time I try to close my hand, my wrist would go this way every single time, because the contradicting muscles, let's say, are paralyzed or extremely weak. So in order for my digits to open, and for my movement to be actually meaningful and useful, I'm opening my digits. So all of those extensors are working very hard to pull me in this to that position, but it doesn't happen. Why? Because the flexors, the carpal flexors, kick in automatically for control, not allowing me to go all the way to extension, but rather to have the smooth control movement. So always agonists are contradicted with antagonists. Now, depend what you want to do. Of course, antagonists are going to work less than agonists, so you can accomplish what you want, but in a smooth, controlled way, right? And similarly, if I want to close my fingers, make a fist, normally it would go this way if my wrist extensors would be weak or paralyzed. But they are not, so I can actually controlled movement, close my fist, and do with the fist what I want to do, because the wrist extensors are automatically kicking in. So it's not only, of course, important because of the functionality of our hand, but you can also appreciate, and I'm gonna take a little gadget over here It's like a brainy ball. And I'm gonna squeeze this ball, right? So let's do it together. Let's take something in your hand, anything, can be pen, pencil, anything you have, doesn't have to be a squeezy ball. So what I would like you to do is go into full this way, full wrist flexion. Let's go into flexion, just like that, and squeeze it hard, as hard as you can, and just feel for your own strength. Okay, now let's go into flexion and radial deviation. Add to it, just like that, and now try to squeeze. This is even weaker, right? So we all can feel really weak, insufficient grasp. Okay, let's go into extension and radial deviation and squeeze it. It's a little bit stronger but not comfortable. Okay, let's go into extension but ulnar deviation now, slight ulnar deviation, and squeeze it hard. Now we can do it, right? Now we can do it. So I would like you to do it with me because I want you to feel on your own body and not just trust my words. So in other words, we just proved to ourselves that the strongest grasp we have is when the wrist is in extension and slight ulnar deviation. How much extension? Approximately 35 degrees of carpal extension or wrist extension and about 5 degrees of ulnar deviation. So this position of the wrist is the strongest. How important is this to know for therapists? You tell me, right? Okay, let's go to next slide. And we have a lot of mobility in our wrist, but of course that's come with some problems. Okay, so we can damage or overuse certain muscles like flexors and extensors of the wrist, and the point when they originate, it can become inflamed and swollen and painful. So one of those conditions is called medial epicondylitis, in other words, golfer's elbow. So it's of course caused by forceful repetition of the flexor carpi radialis, pronator teres, and flexor carpi ulnaris. So all the flexors pretty much of the wrist and the pronator. How can you test for it as a therapist? Test with elbow flexed to 90 degrees. Patient's forearm is in supination and the wrist in extension. Positive sign reveals pain over medial epicondyle. Very easy test to perform. Let's go to the next slide. You got a lateral epicondylitis. It's also known as a tennis elbow. It's inflammatory response to lateral epicondyle involving wrist extensor muscles, and of course we got a few of those, but all of them are involved and they are become inflamed and very, very painful. Test for the tennis elbow, it's a little bit more complicated, but just look at the picture, the drawing over here, and follow the directions, and it's fairly easy to perform. So test with elbow flexed at 90 degrees. Then ask your patient to pronate the forearm, extend and radially deviate the wrist all at the same time. You as a therapist then apply resistance, not allowing the patient to go to all of those movements. And of course the positive sign would be the pain of lateral epicondyle. Okay, let's go to the next slide. There is no next slide, so I guess this is it for now. Thank you. I hope you enjoyed this presentation, and I will see you shortly. Bye.